Here are my disclosures. During this session, these are the sort of the objectives for the session. I'm going to first review the pre-NATS data on STI co-infections in vaginitis, specifically in Candida vaginitis, Trichomonas vaginitis, and bacterial vaginosis. And I think by the end of the talk, you'll kind of figure out which of those is my favorite. We're also then going to discuss the STI co-infection data from a NATS clinical study, so kind of moving up a notch in terms of sensitivity. And then lastly, we'll just take a few minutes to explore algorithmic testing for STIs in women with vaginitis. So I probably don't have to tell this audience that vaginitis is a very important reason for women to visit their care providers, and that most women experience vaginitis in their life. What I'm going to talk again today, as I mentioned, are the three primary causes of vaginitis in the reproductive years: Candida, Trichomonas, and bacterial vaginosis. And these can be either single infections or can be multiple infections, depending on the case. So here we have kind of the breakdown for BV. The prevalence in the general population is about 25%. In our STD clinic population, it was pretty consistently 50 to 60% prevalence. Candida, about 25%. And TV, we kind of have the market on TV, would you say, Bobby? Yeah. So we had quite a few women, about 25 to 30%, I would say, is what I recall, with Trichomonas in the STD clinic population. In the general population, of course, these numbers are somewhat lower, but still probably the percentage across the table is the same. So Candida is the most common cause of vaginal complaints after BV. And interestingly, about 75% of women will have had at least one episode of a yeast infection in their life. And for those of us who have experienced this, it's not a lot of fun. So there's also a group of women who have problems with recurrent yeast infections. And we know that many patients do self-diagnosis and OTC remedies because those are available for women who feel they have this condition. And I might add, as we all know, that many clinicians also do empiric diagnoses for vaginitis, which is not very helpful. In terms of the clinic, if you're lucky to be in a setting such as we were in the STD clinic at Jefferson County and have good microscopes and good microscopists, we like to look at the wet prep and look for the pseudohyphae of Candida. However, we know that this is not a very sensitive method of diagnosis. In terms of Trichomonas, we heard from Dr. Vanderpool that this is very, very common STD, even though some people are in denial about it. You can see the numbers here. It's also interesting with Trich that it has a high prevalence in older women. And people aren't quite sure why that is, but I think it's because of sort of a cumulative effect, because we have no screening program for TV. I think women just go undiagnosed and sort of, like I said, continue to accumulate. It definitely also is undiagnosed. And in terms of consequences, we heard from Dr. Vanderpool about preterm birth, HIV, and concurrent STDs. And I'll go into that in just a little more detail in a second. And here, of course, is the favorite, not my favorite, but my second favorite, the wet prep that looks at motile trichomonads, and the sensitivity of this, we know, depends on the skill of the microscopist, but it's probably somewhere between 50 to 70% would be my guess. Dr. Vanderpool mentioned HIV, and I think that this is probably the STD that Trich is most notorious for being associated with. There are many studies out there that have confirmed this association. This is just one that I chose, where they did a prospective study in Kenya. They did monthly visits and lab testing, They enrolled HIV-negative women, and they found that women with trichomonas had a significantly increased risk of acquiring HIV during the course of the study. So really important in that regard. And this is another sort of interesting, I think, side discussion on this, in that this was a study where they looked at treating women for trichomonas with metronidazole, and when they did this, they found a significant decrease in HIV viral load. So obviously this would help to decrease transmission of HIV in these populations, so definitely a tight association. And then lastly, bacterial vaginosis. We're familiar with the AMSL criteria that's used in clinical settings, pH, whiff, clue cells. And then the Nugent criteria, which is not usually used in laboratory settings. I know there are some labs that do it, but more often it's a research tool. And here you see the sort of the progression of what happens. You have normal vaginal flora on your right, no, on your left, thank you, with predominantly lactobacillus bacteria and not as numerous bacteria. And then you progress to intermediate vaginal flora where you start to lose the lactobacilli. You start to get an overgrowth of Gardnerella and other anaerobes, and then finally bacterial vaginosis, where you're really hard-pressed to find a lactobacillus morphotype and have like tons and tons of bacteria present. We do know that, I mean, somebody may ask me, well, what causes BV? I mean, everybody asks me what causes BV, especially the patients. They want to know, how did I get this and what is it? But I think that our best understanding right now is that Gardnerella has kind of come back into favor as the keystone pathogen. And in my opinion, may be sexually transmitted. And once it gets in there, it alters the vaginal environment. It reduces the redox potential, increases pH, which is unfavorable to lactose and very favorable to strict anaerobes. And that then results in the BV biofilm. So just to kind of summarize that, what are the relationships between these three causes of vaginitis and STI acquisition or prevalence? With STIs and VVC, vulvovaginal candidiasis, there's really no impressive data to link them together as risk factors. And I think that's probably because women with pure VVC maintain a normal vaginal pH and maintain a lactobacillus predominant flora. For STIs and trichomonas, trick obviously is an STI in and of itself. There were older studies suggesting that trick was an important risk factor for gonorrhea. Those came out of the CDC, I think, many years ago. And then we mentioned the impressive data for HIV. BV and STIs, there's lots of data. It strongly suggests that BV is an STI also in and of itself, although nobody's actually proved that per se. And there's many studies out there. I think some of the most impressive studies are the prospective studies that have shown that if you have BV, you're more likely to acquire things like herpes, HPV, HIV, gonorrhea, and chlamydia. So kind of across the board with BV and STDs. This was a study, this was from a small study we did many years ago, but I thought I'd throw it in here because I always thought it was kind of interesting, where we took women who had BV and treated them for BV and then kept them on twice weekly prophylaxis. And the rationale for that was because BV tends to be very recurrent. And so we were trying to keep them as normal as possible, if you will, for the duration of the study. And we were looking at whether or not treatment would prevent episodes of STDs. It turned out that in this study, the only significant relationship was with BV and chlamydia, but there was a significant decline or decrease in prevalence of CT cases in the BV treatment arm compared to no treatment. So again, I think that speaks of the importance of abnormal vaginal flora as a biological risk factor for some of these STDs. Okay, so now we're going to talk about the Aptima BV and CVTV clinical study. And this was a study that was done 21 US sites, and you can see the little dots on the map of where it was. A very large study, about 1,500 symptomatic women. These are not asymptomatic, they were symptomatic. And you can see the schematic where they had the patient collected for TRIC, FDA NATS, which was the comparator at the time, and their Aptima BV CV TV test, and then clinician collected for Nugent and Amsel, Aptima BV CV TV, TRIC culture, and Candida culture. And you see below that sort of the gold standards that they used for diagnosis and comparators. So in terms of the vaginitis portion of this study in the clinical study cohort, you can see this pie graph, very much like Dr. Vanderpoel showed us with STDs. And you can see the various types of vaginitis. And so we see that about 2/3 of all these women had at least one of these forms of vaginitis, whereas about 1/3 were negative. 1/3 had BV only, 16% yeast only, 2% TRIC only, and then there was a fair amount of mixed infections, which I think a lot of clinicians kind of don't realize. I think they get focused on, well, obviously this is yeast infection, obviously this is BV, and they don't take into consideration that you can definitely see mixed infections. And so then the question was asked, well, what is the STI distribution in each of these categories? So in terms of the vaginitis and STI study, it was the same cohort. About 1,000 vaginal swab specimens were tested from this cohort, looking at Mycoplasma genitalium, TB, chlamydia, and gonorrhea. And they assessed the associations of STI infections as determined by NATS diagnosis, the clinician clinic diagnosis, so like, you know, if you looked at a wet prep or you just said, oh yeah, well, I think that sounds like yeast or whatever, and then the usual laboratory reference standard, which I referred to before. And then they compared those types of diagnosis with the STI rates. And you can see listed here, I'm not going to go through these again, what the comparators were. If we look at the Aptima and NAT STI prevalence by clinician diagnosis, so one might say this might be the least sensitive or the least accurate, at least, of the different gold standard diagnoses that are used out there, you can see that 45% of the women with STIs, and they're looking again, let me remind you of TRIC, chlamydia, gonorrhea, and MGent. 45% of these are in women with clinic diagnosed BV. And 93% of those infections are MGent and or TV. So obviously MGent is kind of weighs heavily on a lot of this data, and it depends on how you view MGent in your practice, and I think there's still a lot of controversy about this. So that needs to be taken into consideration, but still, all in all, 1 in 4 women with a clinician diagnosis of BV had an STI, and 1 in 10 women with a clinician diagnosis of yeast had an STI. So fairly impressive. Now if we look at the laboratory vaginitis diagnosis, so a little bit more sophisticated way of diagnosing vaginitis, we see the same trends. BV positive always stands out. BV positive, even in combination with CV, is going to be significantly associated. And on your right, you can see the odds ratios and the significant p-values. So BV positive versus negative, significant difference for Mgen and CT. I think we're not seeing very good data for GC just because the number of cases of GC in this cohort was rather low. So I think it's difficult to see those associations. In this particular analysis for yeast infections, there was not a significant association. With TB, positive versus negative, yes, an association with all three, with gonorrhea kind of coming in. They're kind of confirming that older data. I thought this was kind of interesting, confirming that older data from CDC. And any BV, Candida, TB positive versus all negative, again, Mgen and chlamydia were significantly associated with that. This is just to kind of dive in a little bit more toward BV and VVC. Again, what you see here is a really significant relationship between BV and STDs. Even in BV positive and CVV positive, if they had both, the significance remains. So BV remains the driver in a lot of these women. And Mgen is the same. Again, with GC, we just weren't seeing many infections there. This is another way to look at NAT distribution, NAT STI distribution in symptomatic women by the laboratory BV diagnosis. These things kind of make my head swirl sometimes, but suffice it to say, it's just trying to tell you that not only are there single infections, but can be mixed infections among these groups. And BV positive women had a 26% STI positivity versus 11% in BV negative women. So I think that's kind of a very important biomarker to remember. I threw this in. I thought this was kind of interesting too, because if you remember the slide I showed you of progression of normal flora to intermediate to BV flora, things start to change in intermediate flora. We also know not only does the flora start to change on the gram stain or on if you're doing detailed cultures, which people don't much do anymore, but also cytokine production increases. As soon as you get Gardnerella coming in, cytokines start to increase as well. And you can see from this plot that although we do have STIs in women who have 0 to 3, which is the normal Nugent gram stain, it does start to increase when you get to the intermediate, 4 to 6, and then definitely in the 7 to 10 zone. So I think this is important to remember, that it doesn't necessarily have to be pure BV, that as soon as the flora is starting to change, people are going to be at increased risk for STDs. And I think this is particularly true for Trichomonas. Trichomonas tends to, a lot of people get a little bit confused when they look at wet preps with Trichomonas because they know that something's not right with the flora and the pH is high, so they think, oh, well, maybe she has BV too. But actually, most of those women have intermediate flora. There have been changes because Trichomonas does not like acidic pH, and so there have been changes in the flora, and most of those are intermediate changes with Trich. And then if we look at the STI prevalence by age range, it's pretty much what you would have anticipated, highest in the younger age categories, but still, especially Mgen, kind of over in the older age categories. And as I mentioned before, although this doesn't really show it, Trichomonas has a cumulative prevalence in older aged women. So, could we think of a scenario where you could use the NATS diagnosis of BV and candidiasis as a risk-based approach for reflex STI testing? In this slide, if you looked at, again, these symptomatic females, self or clinician collected vaginal swabs, you can see that the prevalence by STD category, again, is highest among those women who have BV, either alone or in combination. And And even across the board, again, Neisseria gonorrhea, not that many cases. MGent, definitely higher in those patients with BV as well, and also higher in those patients with Candida. So any STI, 16% in BV positive, Candida negative, 13.5% BV positive, Candida positive, and in those who are just Candida positive, almost 10%, versus 5% in those who are BV negative, Candida negative. So we thought about it a little bit, and we kind of came up with this scenario. I'm sure it can be refined, but I think it's sort of an interesting way to think about things. You have a patient who comes in with complaints of vaginitis, because remember, the data we have now is dealing with symptomatic women. As a clinician, I should also be doing an STI risk assessment. How many partners have you had? When was your new partner? Blah, blah, blah. So that's important, and I can kind of put her in a high-risk category or maybe not so high-risk category. If she's high risk with the STD factor assessment, I think the most prudent thing to do is to go ahead and test her for vaginitis, but also because she's high risk with behavioral factors, to go ahead and order the STI testing as well. If she's low risk for behavioral factors, go ahead and order the vaginitis testing. And if any of those are positive, BV, CV, TV, then reflex test, allow the lab to reflex test for chlamydia, gonorrhea, and MGent. If they're all negative, leave it at that. You're done. So as I said, I'm sure this can be refined. I know that the labs do some types of reflex testing, that's something that's not unheard of. I think with HIV, there's a lot of reflex testing that goes on. So I'd be interested to get feedback about this idea and see what you all think about it. So in summary, among this large clinical study cohort, about 2/3 of women had vaginitis due to BV, CV, or Trich, and 1/3 did not have any unknown cause of vaginitis. I saw a lot of those women. They kind of are pretty convinced something's wrong, but maybe not. The chlamydia, gonorrhea, and MGent data was very similar in the cohort to published data. Most of the STIs are found in women diagnosed with BV, CV, or TV, and 45% in women with BV alone. Chlamydia and MGent significantly associated with BV, 2 to 3-fold increase, and also associated with TV. Birds of a feather stick together. We know that STIs travel together. Clearly, the only infection out here that I would say is not necessarily an STI would be Candida. Thinking about this reflex testing algorithm and considering the data that's been presented, I feel like this would be a good, at least a good study to conduct, and if not, even putting into practice right now would maybe benefit our patients. So I'll take any questions you might have, and I appreciate your attention.